Well, first of all, I'd like to thank Dr. Semelis and the organising committee to inviting me to talk to this amazing meeting. It really is a privilege for me. Sorry, I'm just trying to get this. Yeah, I think one of the questions that may be being asked by the audience right now is, what is the LRE and why was it developed? And in answer to this question, I think we just have, it would be worthwhile having a quick look at the history of total elbow replacement, which pretty well mirrors my own career, which started in the mid-1960s as a medical student, and that's when we started doing joint replacements for arthritis. The history of total elbow replacement, interestingly, is the same as total knee replacement, in that they both began in the mid-1960s, and the implants used for each were similar. There were uniaxial metal-on-metal designs. Unfortunately, they all failed early because these joints aren't uniaxial hinges. But during the 1970s to 80s, the use of link designs in the knee ceased, and further developments took place. So by the end of that decade, the condylar-shaped components that we're all familiar with had been developed and are still used today. But in total elbow replacement, it's already been touched on, the development diverged into two different types of designs. There were more sophisticated link designs, and unlinked designs were developed. And both of these designs were similarly effective in the patients who were treating at that stage, those with severe rheumatoid arthritis. But by the mid-1990s, things had changed a bit. First of all, we were seeing fewer patients with this severe rheumatoid arthritis mutilans picture, and more treated rheumatoid patients with good bone stock. And we were also treating primary osteoarthritis, and we were finding by then that the satisfactory long-term results in total elbow in severe rheumatoid contrasted with early loosening and implant failure in patients with OA, and that's irrespective of the total elbow replacement design being used. So the question arose, is there something different in the biomechanics of the elbow between primary osteoarthritis treated rheumatoid and arthritis mutilans? And the answer to that question remained unanswered, but nevertheless, by the end of the 20th century, I'd reverted to treating elbow arthritis, particularly in younger patients with the non-implant options, open arthrolysis and debridement, or arthroscopic debridement. And it was actually elbow arthroscopy, to me, was the game changer, in that we were, to our surprise, finding in our arthroscopy of patients with very severe pain but little or no X-ray change, we were finding that they had completely lost the cartilage from the radiocapitellar joint, which contrasted with perfectly preserved surfaces in the ulnohumeral joint. And we noted then that this pattern of articular cartilage degeneration had been seen for the first time by Goodfellow and Bullock in post-mortem studies in the mid-1960s, and then confirmed by others later. And all these were post-mortem patients, but we were seeing the same kind of articular degeneration in patients with painful stiff elbows, either on open arthrolysis or arthroscopic arthrolysis. So by 2002, we reached the conclusion that we needed to think about developing components to resurface the lateral compartment of the elbow. And we looked at various designs available and chose a symmetrical ball and socket design, and the lateral resurfacing elbow components became available to be implanted by 2005. The surgical technique was a modification of our approach to the total elbow. We use a posterior approach. We reflect the fascia overlying the triceps insertion, and then we begin to elevate the anconeus muscle from its bony attachment and continue this dissection proximally, elevating anconeus with the lateral headed triceps, divide the intermuscular septum, and in stiff elbows, if required, we can incise the medial band of the medial collateral ligament. And to get a wider exposure, if necessary, you can elevate the origin of the radial collateral ligament, and then you've got a wide exposure of the joint surfaces. We prepare the capitellum by inserting a wire over a wire guide, and then a surface reamer, and we can use then a spade cutter to create the hole required to insert the peg of the capitellum trial component. And it's a similar technique for preparing the radial head with a wire inserted through a wire guide, surface reamer, and then a peg cutter. And then we can insert the trial implants and confirm that a satisfactory reduction has been achieved. And after that, we can insert the definitive implants, which got a hydroxyapatite coating. And so these are inserted press fit. And then we just repair the surgical approach by repairing the intermuscular septum and closing the soft tissue envelope. It had become evident, however, that irrespective of the cause of elbow arthritis or the X-ray appearances of a joint, the pattern of articular cartilage degeneration was pretty much the same in every arthritic elbow. We had complete loss of articular cartilage from the radiocapitellar joint, but better preserved surfaces on the humeral-ulnar joint. So we broadened the indications for lateral resurfacing and extended it to all patients with symptomatic elbow arthritis, justifying open surgery. And I think we now understand a bit more about the fundamental differences in the biomechanics of elbows affected by severe rheumatoid arthritis and primary or secondary osteoarthritis. In the rheumatoid elbow, the radial head is destroyed, the ulna migrates laterally to align with the long axis of the humerus, and this kind of bony destruction can be treated effectively by uniaxial type of components, whether they be linked or unlinked. But in the osteoarthritic picture, the biaxial configuration of the elbow is preserved. And so with patients with residual articular cartilage on the humeral-ulnar joint, it makes sense to just resurface the lateral compartment of the elbow and restore the normal biaxial configuration of the joint. So where did we go wrong? Who's to blame? Why did we develop total elbow replacements? Well, Minami and his colleagues in '77 published the results of an extensive X-ray study and concluded that elbow osteoarthritis begins with osteophyte formation in the coronoid fossa, electronon and electronon fossa, which then focused our attention on the ulnohumeral joint as being a problem, leading to the OK procedure and designs of total elbow replacement based on this concept. And this X-ray would support Minami's views. However, if you look inside this joint, you find that the articular cartilage degeneration pattern is different. We've lost all the articular cartilage from the lateral compartment, but to some extent it remains preserved in the medial compartment. So where are we now in 2023? It's already been touched on by previous speakers very, very eloquently. The number of total elbow replacements, total knee replacements, and total shoulder replacements performed annually for arthritis has continued to increase year on year. But if we're honest, no good long-term results have been published for total elbow replacement, and there are high complication rates observed despite the introduction of the modern designs. There's no evidence at all that the latitude or the discovery are any better than designs used in the past. And consequently, the number of total elbows performed annually for arthritis has fallen over the past 20 years. And as we heard earlier, so few total elbows inserted now, it's suggested that the use should be restricted to certain designated specialist centres, which I think is crackers, but it's something we could debate later on. So the current thinking that we're proposing is that the hip and shoulder, you can classify these as ball and socket joints, so you can replace them by ball and sockets. The knees are bicondylar rotating hinge, so you can successfully replace the knee with a bicondylar rotating hinge, but the elbow is much less straightforward. We have the ulnohumeral joint, which is a hinge, the radiocapitellar joint was a ball and socket, and the proximal radioulnar joint, which is a pivot joint. So we now think in terms of the elbow joint complex, not the elbow joint, as three separate joints, the radiocapitellar, ulnohumeral, proximal radioulnar joint, all these joints are distinctly different in their form and function, and we think that attempting to replace all three simultaneously for arthritis is usually unnecessary and probably unachievable. And when I think you heard earlier, when things go wrong, they really go wrong. The results of the lateral resurfacing elbow have actually been published. We published very early results in 2007, but our longer-term results have been published more recently, 2018, where there were 30 elbows, mean age 61, with a mean follow-up of 8.3 years. And we were really pleased at follow-up to find that the mean patient satisfaction score had remained elevated 9.3, but more importantly, the implant survivorship at that stage was 100%, and it's remained like that in this group. And the patient range we're talking about, we started the experience with this kind of well-preserved elbow joint that you're not going to do anything other setting on a total elbow in, so that's what it was originally developed for. And when we realized that pattern of articular cartilage degeneration was the same, whatever the cause or extent of the arthritis, we extended that to other indications. And this is particularly interesting to me in that this is a lady who uses walking aids in a wheelchair. So I just wonder if we put in a total elbow, particularly hinge components in this lady, just how long they would have lasted before they required revising. So to bring us up to date, we've tried to push the boundaries a bit of using the lateral resurfacing, and we've used it more recently as a revision option for so-called radial head deficient elbows due to radial head excision or failed radial head arthroplasty. And we found it did work in this small group of patients because the capitellum resurfacing treats the symptoms caused by the capitellum wear erosion that occurs in this group of patients. And the radial head component, although designed as a press-fit inlay for the native radial head, can actually be fixed with cement and augmented, and therefore kind of replace the excised radial head. And we found, interestingly, by adjusting the depth of insertion of the two components, allows the radiocapitellar joint line to be advanced distally, which combined with augmenting the radial head component, if necessary, compensates for the bone loss from the previous procedures. And we also found this is the newer instrumentation, which is sort of single-use, pre-packed sterile instruments. You were able to kind of control the amount of bone removed incrementally, and that the shape and methods of fixation of the implants does allow a degree of versatility in final implant positioning, which we find a considerable advantage in individual revision cases. And whereas we're okay with the primary components for elbow arthritis surgery, we think that the way forward would be to develop components designed specifically for revision surgery in these kind of difficult problems. But, well, thank you very much for your attention.